Hey guys, for those of you who haven't met me, I'm Alex Feitz. I think I know a lot of you by now. Cameron had asked about if I could show some things about shortfoots in one of the discussions last week. I tried using VoiceThread and had lots of problems, so I gave up. So apologies if this is difficult for any of you to access. Let me know and I can help you get a video. So for those of you who don't know, a shortfoot exercise is a contraction of the intrinsic arch muscles to elevate your arch, which puts you into a supinated position. In contrast to a pronated position would be a flatter arch. We use that in our push-off when walking, and also my theory is that we use it a lot with ankle stability. So I'll show how I do that and how I progress that with patients. If they're somewhat athletic and coordinated, I'll just show them, say, are you able to elevate your arch up like so? Some people can do it, sometimes they can't at all. If they can't, I'll walk them through a progression starting with passive and moving towards active assist and then active range of motion. So for passive, I'll have them pay attention to one foot, in this case, let's say my right, and I'll say twist to your right, and as they twist right, it's going to passively elevate that arch for them, putting them into a shortened foot position. As we twist left, it will drop the arch down, drop the navicular into a more flattened, more pronated position. I'll have them do it a couple of times, and then have them try to actively assist that motion. Can you contract your foot muscles as you do this? Some people struggle with this. Often it takes several minutes to really get the hang of it. As they're improving, I'll have them twist less to the point where then can you just do it standing? Can you raise that arch and lower it? Once they get that, then we'll go to, can you go both at the same time? Very rarely have I flared anyone up with this. I've probably done this with over 100 patients, and typically the only issue is if they don't like the twisting because of something else in their body. Progression-wise, once they're able to do that, depending on what our specific impairments are, we can increase the difficulties in several ways. First is by elevating the big toe. If you actively extend your toes, you're going to inhibit the flexor muscles, which are then trying to do a short foot at the same time will require you to only use your intrinsic foot muscles. Most of the time, I'll do this with a heel raise. Can you hold your arches up? Go up on your toes. That will also help maintain more ankle stability so they're not wobbling left and right. Often you'll see when people go up on their toes, when you heel raise, they will drop out to the side or sometimes inwards. This will help prevent that. In terms of specific treatments, so I'm just looking at my notes here, where I'll often use this with ankle instability, be it chronic or first time lateral ankle sprain. We'll go through heel raises, and over time, then can you do it with hopping? Can you not just hop, but can you hop and land with your arch engaged to help soften that landing a little bit more? As that improves, then we'll try single foot, and then forward and backwards, and then lateral. Can you hop and keep your arch engaged, promoting ankle stability? For plantar fascia, as we discussed a little bit, that's a little bit of a blanket term. Most people don't need some strength in that area. Then we can work on holding that arch up with different surfaces. So sometimes on foam would be much harder. Sometimes I'll do it with various other exercises. So maybe can you do a deadlift as you hold your arches engaged? Can you do a squat? Can you lunge? Can you do basically any closed kinetic chain exercise? You'll also see that with people that are getting general foot fatigue. So maybe they've been immobilized and they're getting back into running, their feet get tired. This will be another place that will help. One other diagnostic finding, which works with sometimes patellofemoral pain. We see in our CPGs for that, I imagine we'll cover in a few weeks. Maybe we don't cover patellofemoral pain. Regardless, that one of the categories for that, in addition to quad or hip strength or patellar hypermobility, is foot pronation. Often when that's the case, this is a home run for that person. I've had several patients come with a painful squat, hold up a short a short foot while they squat and have their pain go away. So that can be another place to use that. Feel free to reach out with any questions. It's something I played with and thought about a lot, and I'm happy to discuss it. There's not a lot out on it yet, and so it's something I'm still kind of working through, but I'd love to hear your thoughts and opinions. Thanks.